So moving on, we're about to start the third session, the last session of the day before we do the Q&A. And the chair of the session is Dr. Erynn Christensen. So Erynn is a postdoctoral researcher in the Brain-Based Predictive Modeling Lab at the Feinstein Institute for Medical Research. She investigates the influence of sex hormones on neurocognitive functions. Erynn is particularly interested in the relationship between fluctuations in female sex hormones, neurocognition, and mental health, both across the menstrual cycle and during key life transitional periods such as puberty, pregnancy, and menopause. Erynn earned her Bachelor of Psychology with honors in 2017 at Monash University and her PhD quite recently at the start of this year. So congrats, Erynn. Her PhD focused on cognitive correlates and predictors of addictive behaviors with an emphasis on longitudinal models and cognitive task development as well. So it's great to have you here, Erynn. Over to you in session 3.
Fantastic. Thank you so much, Valentina. So I'm excited to introduce our final speaker session, in which we'll be moving our focus to discussing sex differences in the clinical setting, with Professor Tony George providing insights on psychiatric comorbidity and treatment implications. Associate Professor Anna Zilverstand will then discuss how sex differences should be considered in the context of data collection and how we can break down barriers to recruitment. And finally, we'll conclude this session with Dr. Linda Montanari, who will apply a gender lens. While studying gender effects in the field of addiction probably warrants its own workshop in and of itself, we believe this is a really important perspective to incorporate in our to round out our discussions today. So without further ado, I will introduce Professor Tony George. He's a professor of psychiatry and in the Institute of Medical Sciences in the Temeti Faculty of Medicine at the University of Toronto, and senior scientist at the Centre for Addiction and Mental Health in Toronto, Canada. Dr. George's research is focused on understanding and treating substance use disorders in people with serious mental illness. So I'll just pop up his slides now. And
yes, thank you. Thank you, Erynn.
Over to you.
I think we're
oh, apologies.
There. Yeah, oh, it's okay.
There we go.
So yeah, thank you, Erynn, and thank you for the invitation to be part of this very impressive symposium on sex differences. And yeah, I asked Erynn to share my slides. That's just another thing I don't share well, including slides. So, but I'm a psychiatrist, and I've been studying psychiatric comorbidity with addiction for about 30 years, mostly in tobacco. And most recently, since I moved back to Canada from Yale about 15 years ago, Canada legalized cannabis about 5 years ago. And so I came screaming into that. Just go to the next slide, Erynn. Okay, just my disclosures, but just go one back. Sorry. You know, I saw a lot of, I'm the co-editor of the journal Neuropsychopharmacology, and, you know, there were a lot of nice older papers from 20 years ago. Drs. Goldstein and Becker showed their work, but some of the more recent work by the younger investigators is in places like biological psychiatry. So you know, I've got Ziva Cooper and Erynn Calipari on board at the journal. So if I have to recruit you all to the editorial board or hire, I will to get your work there. So go to the next slide. So, you know, in the area of psychiatric comorbidity and sex differences, there's some good work coming up, but it's very preliminary. And I got, you know, pulled into this work by several of my students. Carolina Kozak, who's in the upper left, was studying schizophrenia. And when you do clinical research in schizophrenia, it's almost 90 to 100% men in terms of who comes in. And so she was thinking about this, and she thought, you know, it can't all be just men in psychiatric comorbidity. So she actually did a nice project, and Ziva Cooper was a collaborator on this, to look at cannabis use disorder and sex differences in people with psychiatric disorders. And so if the ratio of men to women is about 2 in just plain old cannabis use disorder or problematic cannabis use, it's actually all over the place. And so in schizophrenia, as I told you, it's very high. It's almost 3, the ratio of men to women. But if you look at mood disorders and other disorders, it's quite variable. So we got very interested in this general area. And as we started to shift into people with mood disorders, you just go to the next slide. That's a slow slide. So we've been focusing most recently on major depression, which is the most common psychiatric disorder. This is 1 in 8 people in society, particularly in Western society, will be diagnosed with a major depressive disorder sometime in their lifetime. And, I don't have to tell you all about, many of you are probably very familiar with this, but it's highly debilitating. It's one of the, if not the leading cause of disability in the world. It's in the top 3, unfortunately. Just go to the next slide. And one of the things we just don't know about it is how substances, whether it be nicotine, alcohol, cannabis, truly impact on it. There's the self-medication theory, and that's actually been disproven fairly consistently. So people don't use substances to treat their depression and other psychiatric symptoms. It's actually the opposite. It has negative effects. And so when we focused on cannabis, most of the cross-sectional studies, that is stitch in time studies, are all over the place. But if you look at the few prospective or longitudinal studies, they're starting to indicate that cannabis, like other drugs, has very negative effects on clinical outcomes in psychiatric patients, particularly with depression. And we've got into this most recently. Just go to the next slide, Erynn. And so what we've done, a lot of the very nice talks that came before me were giving substances and looking at effects in experimental models. I guess I've never been very good at giving things, but I've been much better in taking things away. So we've been using abstinence paradigms, for 25, 30 years now, first with nicotine and with alcohol, and now most recently with cannabis. And so what we actually do is, after we do a baseline characterization, we ask our human subjects to abstain from the drug, in this case cannabis, for up to 30 days. And if you just do one more click, there it is. This is how we do it. Monetary incentives. So, show me the money, Jerry Maguire, money, money, money. $300 is a tremendous incentive to get people to change their behavior. If you just, it's a multi-click slide, but just click again. Yeah. So after the 30 days, we do a follow-up, and invariably, after we remove the reinforcer, people relapse. So it's sort of like an off, back on again model that allows us to investigate what taking away the drug and then, naturalistically putting it back does to clinical outcomes, cognitive outcomes, biochemical outcomes. I'll show you some of the things we're looking at. So just scroll ahead one more. Yeah, so I already told you that whole bunch of different outcomes we look at. And that's the cool thing about this, is that we can look at multiple outcomes. Of course, that means we just have to have a large number of subjects, but you scroll ahead again, Erynn. Okay, so this is some of the preliminary data when we do this. So this was a pilot study of open label cannabis abstinence for up to 30 days. This is Aaliyah Lukács, one of my former graduate students, who really ushered in the depression cannabis work in my lab about 7, 8 years ago. And what she found was very interesting, is with up to 30 days of abstinence, and that's well beyond the cannabis withdrawal syndrome, which is about 5 to 7 days. It usually dissipates by then. So we can get past that withdrawal. We can actually look at what abstinence does beyond withdrawal. Of course, withdrawal causes anxiety and maybe some initial increases in depression, but lo and behold, after 30 days, depressive symptoms on the most validated measure of depression clinically, the Hamilton Depression Scale, go down by about 50%. And if you look at one of the more crippling aspects of depression, anhedonia, or the inability to feel pressure, that went down about 70 to 80%. So these are very clinically important, significant effects of just quitting cannabis for up to 1 month in cannabis-dependent patients who had major depression. Let's go to the next slide. So we looked at a couple of other outcome measures as we've sort of expanded the study. This is Miriam Sorku on the top and Molly Zhang. And Miriam is my most senior PhD student. And so it turns out if you look at anxiety, that also selectively gets better in people who abstain versus those who don't. Sleep, interestingly, after a month didn't get better. But there are other studies, colleagues at Harvard, at MUSC in South Carolina, that suggest that if you do longer periods of abstinence, sleep will actually start to improve as well. So all these interesting positive effects of quitting, which is cognition. I don't know if you can just slide. Oh, did we miss the slide? I think we just go back one. Oh, I think I'm missing a slide. Okay, that's okay. So let's just go to the next slide. Okay, and so, we are able to, in these clinical studies, look in a large number of clinical and cognitive outcomes, and that gives us an opportunity to study sex and gender differences. Let's go to the next slide. And so I won't spend too much time on this. So this is the design of what we're doing right now, and we got some great feedback from reviewers of these grants over the years, which was great, you can do abstinence, but what about a control group that doesn't abstain? So we settled on a design where half the subjects, and we have a grant from the Canadian Institutes in Canada, the Canadian NIH, to look at these abstinence paradigms in a control setting. So there's half the group is incentivized with money to abstain, and the other half isn't. So it allows us, say, in a control design to look at people abstain versus don't abstain. And also to be able to, in a large enough sample, look at sex and gender differences. And so that's what Miriam's project is all about. Let's go to the next slide. All right, so I'm just showing you a list of the number of clinical measures we're able to look at, and or multiple comparisons and stuff like that. Go to the next slide. We're looking at cognitive outcomes. Just go to the next slide. There we go. Okay. Yeah, and so my lab does a lot of cognitive measure the effort and anhedonia, so we're able to look at both objective and subjective measures. And then the next slide there you showed, I was jealous of people showing the data from their lab. Yeah, just go to the next slide, sorry. There it is. Okay, there's a picture of my centrifuge and my pipettes and some of my team. And so what's really makes us able to do these studies is we have a rapid point of care test that immediately tells us at the end of 30 days whether someone is abstinent or not. It's called a NarcoCheck test. It comes out of France, and it's a point of care test that immediately tells us in a semi-quantitative way whether people abstained or not. So that allows us to give the reward when people want it. And then we send the samples out for more definitive testing with GCMS-MS. So it's really allowed us to do these studies in real time. And go to the next slide.
Tony, I'll just have to get you to wrap up if that's okay. We're a little bit over time.
Yeah, sure. Almost done. So these are just some of the additional kinds of measures we're looking at to try to characterize sex and gender differences. And if you go to the last slide, there it is. Okay. So this is our first foray into looking at sex and gender differences. And as some other people suggested, men seem to have differences in their changes in depression scores. So it looks like men and we have fewer men that abstain, actually have a more robust change in depression scores than the women. And actually, we recruit more women than men, so we have to actually oversample. So I will stop there. And thank you very much. I've already told you that. So I'll just go to the last slide and I'll thank everyone. There we go. There's my team.
Fantastic.
Thank you.
Thank you so much, Tony. That is great. And thank you for wrapping things up quickly. Now I will move along to introducing Associate Professor Anna Zilverstand, who is in the Department of Psychiatry and Behavioral Sciences at the University of Minnesota in the Medical Discovery Team on Addiction. Her current work is aimed at understanding individual differences in the complex mechanisms underlying human drug addiction. Anna collects and analyzes large data sets to gain insights on how social, psychological, clinical, and neurobiological factors interact to drive addiction. So over to you, Anna.
Thank you. Okay. Is this working? Awesome. So I was asked by Valentina to talk about strategies to break barriers to recruitment, particularly of women. And in the spirit of that, which is one of the large data sets that I'm involved in, which is the HBCD study that studies the effects of prenatal substance use on families and the children. And so for that study, we, in the spirit of this picture, we recruit, for example, at events. So we're trying to meet the families where they're at in their free time. Why is it important to think about gender balanced recruitment? What's the state of the field? Rita Goldstein already gave it away. When we looked at more than 100 studies, only about 5% of them actually conduct gender comparisons, which is largely due to the fact that a lot of them do not include enough female participants to actually conduct these comparisons. So therefore, this is an urgent and vastly understudied topic, and we all need to do better in order to recruit more women in research studies. And so this is also important because the gender gap in substance use is closing. And I just want to show one graphic on this. This is the how the percentage of young people who have been binge drinking in the past month over time. So this is comparing the millennials to the Generation Z. The Generation Z are the people that are now in their early 20s. And so Generation Z has finally caught up to men in terms of how much they binge drink, because about a third of them binge drink, equal to men. So and the overall descent in alcohol binge drinking is only due to the fact of an increase in cannabis use that I'm not showing on this slide. And importantly, young women have also caught up in terms of their cannabis and opiate use. And this is thought to be mediated by a change in risk perceptions. So it is still true, based on interview data, that men are more risk-taking than women. However, the young generation, the Generation Z, doesn't perceive binge drinking or cannabis or opiate use as risky behaviors anymore. And hence, women are doing it at equal levels as men. And so Valentina asked me, I'm involved in the HBCD study on prenatal substance use that exclusively recruits women. And so she asked me to talk about some of the lessons learned from that study. And so this, for those of you who do not know, this is a study that is enrolling 7,500 women and following their families for up to 10 years. And is underway since a little bit more than a year, and the first data will be available early next year. And I want to give a shout out to Dr. Brendan Jones-Harden at Columbia University, who has been our fierce leader in the work group that is responsible for developing the recruitment strategies for this study. And we have been meeting for the past 4 years bi-weekly, and I owe her a lot in terms of the inspiration on how we're doing our recruitment. And so, as I said before, where do we recruit women? We try to meet them where they're at. So first of all, we do a lot of recruitment at events. The Halloween event, then there was an event in the park in downtown, and on the right you can see recruitment at the Minnesota State Fair, which was actually very successful. And so other than that, so these are 4 recruitment strategies that I listed here that have been the most successful. So we have certainly tried out dozens of strategies also across the 25 study sites that are involved in this study. And so these were the most successful ones, particularly to also involve vulnerable women. So the most successful one for recruiting women with history of substance use disorder has been to use intimate settings. So we were allowed by our clinical partners to join group therapy sessions and simply chat with women or join them over lunch. And that has been our most effective strategy to simply get into a conversation with them. And similarly, our recruitment for community partners, such as county programs that are very involved and where women come to the program daily, have been the most successful ones. So we're really in sort of an intimate setting. And then the last one that we have been using very successfully is mobile recruitment. And so in this demographic, so this is women at childbearing age, we have recruited 80% of them through mobile recruitment. So either through MyChart, Facebook, or email. And so another important piece of our recruitment strategies, especially because the mobile recruitment is such a big part of it, after the first, they raised the first interest in participating, there are many phone conversations. So my recruitment team consists of 3 people, and they have told me that on average it's about a dozen phone calls that they have with a woman who is interested before she enrolls in the study. And there's lots of form back about all sorts of questions, and they go back to their family and then call again. So we have full-time recruitment staff for this study, and it is necessary in order to make this possible. One of the 3 people is a certified peer recovery specialist from a recovery connection organization that specializes in supporting women with a history of substance use, and this has been invaluable. And I have to say, when we go to these like group therapy sessions, that is the key predictor of success is if we have our certified peer recovery specialists, women are far more willing to sign up for the study because they know that there's somebody in a study team that understands their concerns. And all of this has also been accompanied by the community advisory board that we have, where we have healthcare workers that we have recruited through this Project ECHO talk series on perinatal substance use. And so they have been advising us on top of all the advice that we get from other universities on how to best do this. And this is what we have come up with in how to recruit and retain women. And so one very important aspect of this has been to create comfortable spaces in which women feel comfortable. And so we are very lucky to have a very nice building, but I know that all the 25 study sites, they have really made an effort to create spaces in which families feel comfortable and like spending time, so that we can not only recruit them, but that they also come back for this longitudinal 10-year study. And the second most important lesson that we've learned over the years is that incentives is, there needs to be a very broad approach to incentives. So we pay participants $40 an hour, which is $20 for the mom and $20 for the child. But we also very generously reimburse any mode of transportation, and we even provide hotel stays if they come from further away. We also provide food, childcare for older siblings, a crib, the lounge space. We have a research closet for where they can take items home, baby items. We have diapers, and I'm talking about boxes of diapers that we hand out. And we have been told that the diapers is the #1 reason for some people to come back. And then also little things for mom, coffee cups, chocolates, and so on. And this is important not only for people to come back, but also if we can create a positive experience, they will tell other people. So in the meantime, we have sort of gotten a wait list for people to sign up for the study. And I think one very important aspect of this is not just the monetary and the tangible incentives, but also the experience. And so my team does the Minnesota Nice, so they smile whenever and whatever happens. But we also pamper our participants because we don't give them limited food choices. We give them a whole menu of several restaurants and they can choose, and they tell us that they love this. Especially the low-income families, because they can't usually do this. And then there is light touches such as birthday cards or photos. And as we move into the longitudinal part, we'll have yearly events where we talk to participants about the research that we're doing and the findings that we have that we call Coffee and Talk. And last but not least, there is also into the study, what's baked into the study is that we, when we do things like we do cognitive testing with the infants and toddlers, if there is actionable results, so if there is, for example, a cognitive test in the lowest 5th percentile of the cohort, then they will get a phone call from a clinician to tell them about this and to take the report to the pediatrician. So it's not only the monetary value, but we're trying to create value in all sorts of ways. And really trying to make it a valuable for the study participants to be in the study. And we have seen that this is like really boosted recruitment, and we have currently a retention rate of over 95%, which I've never had before we've done all this. And so I just want to, before I end, I just want to plug, like, why is this important? This is some research done in my lab by my grad student, Andrea Maxwell, on gender differences in social relationships and how this influences substance use in men versus women. And so this is just to stress why it's important to include women in the research, because there are certain things that are different. This is, of course, I'm talking about gender differences here, not about sex differences, because this is related to social roles. But it's also related somewhat to biological differences, the increased risk-taking in men that has been mentioned a few times. And so what we found is that when men have more companions, more friends, they have increased pleasure seeking. So they will go out and have fun together and drink more. Whereas when women have more companions, it will support them to reduce their stress, and they will actually drink less. So we have this opposite effects of companionship and friendship in adult men and women, also in teenagers and even in children. And that's my last slide.
Fantastic. Thank you so much, Anna. That's actually a really brilliant way to segue into Dr. Linda Montanari, who is a health sociologist working at the European Union Drugs Agency as a principal scientist. With the centre, she coordinates 3 key areas: gender and drugs, prison and drugs, and psychiatric comorbidity. And in the area of gender and drugs, her work aims to systematically integrate a gender perspective in the European drug field, including monitoring and recommendations. She coordinates the European group on gender and drugs, and also coordinates an internal group aimed at including gender, equity, diversity, and inclusion perspectives in the organisation. So over to you, Linda Montanari. You're just on mute.
Thank you very much. I try to share. Can you see it?
It's just coming up now. Perfect.
Yeah, okay. So thank you for the invitation to this important event. Thank you in particular to Valentina Lorenzetti. I think I congratulate you really for organizing this event where you put together these different dimensions. So I will provide you like broader presentation based on the data that we are collecting at the European Union's Drug Agency, which is an agency of the European Commission that work with the 27 European member states plus Norway and Turkey. So when we look at the drug field, we see that often this is treated as a gender neutral or gender blind phenomenon, while in fact finding of research and on the intervention, they are still mainly addressing men. Very little is known on other genders that are not and different sexual orientation and drug use. While when we look at the first data, we know, for instance, the latest data from 2022, that 33 million females and 50 million males have used drugs, illicit drugs in Europe. And also when we look at the sex and gender differences in risk factors, behavior, and consequences of drug use, we saw that there are large differences. I don't repeat the concept of and the definition of gender, because I think this is really important when we look at the data and the epidemiological data on the drug issue. So what do the available epidemiological data tell us? First of all, here is a graphic on the lifetime prevalence of drug use and the males to female ratio among all adults in Europe by substance. So the data are collected by biological sex still, even if we start to collect data on gender as well. As you can see, of course, the highest prevalence is for cannabis, followed by ecstasy, amphetamine, and cocaine. But when you look at the ratio between males and females, you can see that the lowest ratio is reported for cannabis and the highest for cocaine and amphetamine and ecstasy. It's like the more, so in this, and here it comes the concept of the social concept of gender, because cannabis is among the most normalized and acceptable, socially acceptable substances. And if we look at the prevalence in the graph on the right for alcohol use, you can see that in most countries, the differences between males and females is low, is smaller, and in some countries, 13 countries, even the percentage of females is higher than the percentage of males. And now, if you look at the trends, because if we look at gender only is not sufficient, we have to look at different aspect, including the age. For instance, here is the trend in the 15-16-year students in 23 European countries, and if you look at the gap between boys and girls in illicit drug use, the gap between 1995 and 2019 is still quite similar, while when we look at the heavy episode drinking, the gap seems to be narrowing, and this narrowing is so the prevalence is similar between boys and girls if we look at alcohol use, which is illicit substances, and also the behavior is more like socially acceptable, especially for girls. And again, another intersection that is important to do, so it's not enough just to look at sex at age, but we have to look at the different generation and the intensity of drug use. So in the graph in the left, you have the demographic characteristics of the respondent of our web survey on drugs, more than 50,000 people that are using drugs that have responded to this survey. And as you can see, the percentage of female is increasing, while at the lower in the youngest generation. And in the other graphic is reported an indirect information on intensity of drug use, which is an information that is known in literature, and more intense is the form of drug use in the last most prevalence, as I say, is an indirect indicator, then the male-female ratio is higher. So the proportion of males are more when we look at this most intense form of drug use. Another, I think, important information is that we cannot look at people who use drugs as isolated population group, because they are a population group that is living in a social context. So in the graph, the map that you can see here is reported the male to female ratio of the people that are entering drug treatment in 2022 in Europe. And the darkest the color, the highest is the male to female ratio. So you can see that the darkest colors are reported in the southern European countries, while the clearest, so the more equality in the behavior regarding drug use or access to treatment, is reported in the northern, in particular in the Scandinavian country, which correspond, and this is the graph on the right, to the information reported in the Gender Equality Index, which is an index created by the European Institute of Gender Equality, looking at different dimensions in the general population. The quality in European Union is 70, while if you look at Sweden, it's more than 80, and another country of the south of Europe is much, much less. This is one of the few data that we have on drug use by gender divided by binary and non-binary persons. So also reported from the web survey. Is the sample is quite small compared to the overall samples. It's only less than 2% of the general sample, but as you can see, there are some differences, even though they are not statistically significant, but there are differences with the non-binary person reporting higher prevalence of use for heroin, amphetamine, and ecstasy. Then again, if we look at the consequences of drug use, and this is the HCV prevalence among people who inject drugs, males and females, in studies conducted since 2000 in 28 countries, you can see that the percentage are more similar. Of course, here there are countries where the percentage of females overcome the percentage of males. And there are several factors. It's probably one of the data where you can see more clearly how the sex and gender interact, because there is it is known a biological vulnerability to contract infectious diseases, but there are also behavior that are more common among women than compared to men, like sex work, where women have less power of negotiation for using protection, so are more at risk of contracting infectious diseases. And finally, another interesting epidemiological data is on overdose deaths when we look at the suicidal intent among females and males in 13 countries. As you can see, in all the countries where the data are available, the percentage of women overcome the percentage of men with suicidal intent for overdose. And this may be related again to several factors, psychiatric comorbidity, as it was mentioned before, but also it might be also related to different ways to report the suicidal intent among the doctors, in the toxicologists, etc. So there are several elements and several factors that should be better understood. So then when we look at the intervention, we try to, we collect from the European countries report on different type of intervention related to drug use. And when we had look at how the gender perspective was reported, it was here, first of all, it was not very much reported, but also because we didn't ask properly this question, it was not systematically included. But when it was reported, the main intervention with a gender perspective, they were targeted pregnant women and mothers, which is of course an important issue, but is not the only one. And there was only one program that we found that was targeting fathers. So there is a lot to do also in terms of intervention. And of course, all the studies from a biological and sociological perspective can really help to identify what are the most appropriate intervention, and that can be also more effective. There are examples that are good examples, also gender responsive intervention. Just mentioning in Ireland, they have an experience of trauma-informed intervention. There are several countries where they have specific services for instance, for women, or in Sweden, where they included in all drug policies the specific services. So what to do to towards to include more gender responsive intervention. There is an interesting assessment scale of health intervention. I won't go through it because of time, but it's really useful too when we look at the intervention, also targeting drug users, to try to understand where is located this intervention. Is gender unequal, so perpetuated inequalities, or is more looking at the gender specific issue or gender transformative. And finally, I would like to highlight that in 2022, Sweden had the presidency of the Council of Europe, that is rotative every 6 months, and provided some clear recommendation on how to include the gender perspective in the drug data. So first of all, collect sex and gender disaggregated data, and there are specific data quality recommendation of the European Institute of Gender Equality that is recommended to use the two-step approach, so to ask always data and to present the data by biological sex and by gender, to include the gender perspective in drug policy, to have a multi-sectorial, multidisciplinary approach, to address the gender gaps, to have a participatory approach, and to focus on international processes, and finally, the EU drug strategies. So I thank you very much. You have more information. Just would like to inform you that on the 22nd of October in Lisbon, there will be the second Gender and Drug Symposium, where we try to look at all these issues together. Thank you.
Fantastic. Thank you so much, Linda. We'll now have about 5-ish minutes for some questions. I invite everyone to turn their camera on if you'd like to engage. We'll kick things off with a question from Nihal. Is it possible that patients are using drugs to treat their symptoms accurately, so mood, anhedonia, etc., that lead to bad outcomes? So their motivation is to treat themselves, but the eventual outcome with chronic use may be worse. So this is directed at Tony.
Yeah, so that's a great question. And, you know, the clinicians have long speculated that self-medication, when they talk to their patients, you know, is a very meaningful thing. What I would tell you, based on the studies that we and many other groups have done with longitudinal stuff, where we, you know, take drugs away, have actually suggested just the opposite, that symptoms actually improve. There's a really nice study in JAMA Psychiatry looking at alcohol effects in bipolar disorder. Yet another study that showed that alcohol administration does very bad things to bipolar outcomes. So the preponderance of the evidence is really suggesting the otherwise. What I think is often going on, where there's a little bit of dissociation, is if you look at, you know, early withdrawal effects, which can cause anxiety, depression. You know, if you ask patients, participants about those early effects, then you will conclude, oh, they must be getting a direct benefit, because the substances, whether it be cannabis, alcohol, tobacco, are alleviating withdrawal. But if you can get past the withdrawal period, then you can probably reveal what's truly going on. And the preponderance of the evidence is just the opposite. The drugs are making things worse. And when you get people into treatment and take them away, they actually get significantly better. So.
Thanks, Tony. I mean, simply put, I guess it could just be a dissociation between acute effects of the drug and long-term effects of the drug.
Exactly. But I would argue the long-term effects are probably most relevant clinically for outcome. So it's a controversial area. So
great. Thank you, Tony. I have a quick question for Anna. So it's absolutely brilliant to see how engaged you and the team are with your participants, and a 95% retention rate is absolutely ridiculous. That's incredible. But I noticed that a lot of these things that you're doing, they cost money. and they also take time and resources. How are you factoring this into your budgeting when you're applying for grants? Are you discussing it in your applications, or are you managing to kind of just take money from other bits, just from a practical sense?
Yeah, so we have budgeted many more things than in previous studies that I've done. And I've now also started to factor this into previous studies, because in previous studies, we've often only had 60 or 70% retention. And so I do think that it's money that's worth investing, because you can't use the data in a longitudinal study if you have of the people that drop out of the study. We've also really made an effort to use donor money for these kind of things. So there's certain things that aren't allowable from NIH funded funds. So this is a great thing to suggest to donors to invest in these kind of things.
That's a really excellent point. I've got another question here from Valentina to Tony. We observed in our work that brain activity during the monetary incentive task is not very robustly recruited. I wonder if the incentive has not really consolidated and reinforced the behavior at a brain level, so monetary contingencies might not be sufficient to support enduring effects.
That's a great question, Valentina. One of the things I didn't mention is we actually would like to image these people, and you pick your favorite paradigm, because, just looking at these clinical outcomes, cognitive outcomes, we don't know much about mechanisms. So that's a great point. And we don't really understand truly what the mechanisms are. So we're trying to get funding right now to do some of what you're suggesting, I think.
Well, we have some imaging data, Tony, as well. So I'm happy to follow up with you as well.
Oh, right. Yeah.
Fantastic. Were there any other questions? I'll give a little space if anyone wanted to pop their hand up. But otherwise, we're going to take a short break.